Okay, good afternoon, everyone. Thank you for joining us this afternoon. Dr. Alaikum, good afternoon.
Good afternoon, sir.
So here is another webinar.
Yes.
So this afternoon we'll be talking about syncope, and we promise to make it an interesting session. Hopefully, we'll all find one or two things to learn from the discussion.
Yes.
So once again, I'm Dr. Oyindamala Ofisoi, and with me here is
I'm Dr. Olaleko Olale, and I want to welcome everybody again to another session of discussion about medical topics. And the purpose is for us to improve ourselves, share knowledge, and get to know one or two things about some of the common complaints we face.
Absolutely. Okay, so this afternoon we're talking about syncope, Dr. Ladikon. I'm sure that everybody has encountered a patient or two in the past that was said to collapse. In cardiac care here, we probably see at least one almost every other day. And we know that people passing out is actually quite common.
Yeah.
And sometimes it can be scary. Sometimes for some people, they don't feel it's so scary. And but I think as doctors, we always need to brush up our skills in evaluating such patients that were brought in to have either recently lost consciousness or it just actually happened right there on the scene.
Yes, because it is actually a great challenge when we face situation like this. Because,
Absolutely.
like we know, the general panic that this person has fallen and it is epilepsy.
Absolutely.
Someone is pouring water, somebody is dragging the leg. So it's always a great challenge, both for the weak people that are around the person when the incident occurred, and even the doctor that is saying that what am I facing now? What is the cause of this?
I've actually seen interesting collapse scenes even in the hospital. I mean, in the hospital, you expect that the response to it should be the healthcare worker should be confident and all of those things, but I've seen pandemonium occur in the hospital because the patient collapsed while getting an injection, while the blood sample is being drawn and those kind of things. So I think everybody should be able to relate to this topic.
Yes, everybody.
Okay, so I think before we go on, we'll discuss a case, one of the cases we've seen before. So here we have a person that is a 53-year-old man and who has diabetes and hypertension, and that was brought in with transient loss of consciousness. We're thinking it's syncope now, but maybe we'll decide what we think it is. And he was taking a break after a long day at work. He was drinking a cold beer, and then he felt pins and needle sensation in his neck. He felt numb around his mouth. He felt uncomfortable in his tummy, and then a bit of tingling in his forehead. I know that this amount of details, actually, we hardly get that from a patient that's passed out. Okay, but we have this in this case, and then as he was calling for his wife, he lost consciousness and then he passed down to the ground.
Yes.
And he was unconscious for about a minute. His body was quivering to some extent. And then when he regained consciousness, he was confused for some moment and disoriented. And then his wife reported that it was cold, it was clammy, it was sweaty, and he had some minor bruising on his body. If you have this kind of scenario, what should be going through our mind, Dr. Ladekon?
So this patient now, we said, okay, this is someone that's collapsed for a few minutes and immediately he was able to get up. So some of the things that will be going through my mind is, okay, is this something benign or is this something that the doctor should take an urgent action to make sure that there's nothing sinister in the background? Because once someone collapses, the first thing you want to say, okay, is this something that we can take with a pinch of salt or something that we should be aggressive with? So that's the first thing, and that's the major challenge that we face as a physician, to know whether this is a benign problem or something malignant or something sinister in the background.
And I think at the end for every patient that collapses, we should actually find out, we should think within ourselves that is this person at risk of sudden death from another collapse? And then is it likely to recur? Because we don't want this kind of a thing to recur. So here we are, anyway, this patient that we have here had some minor bruising, and he was disoriented for a while after the transient loss of consciousness.
But
luckily, he didn't survive he didn't have any head injury. So there's no previous history of syncope, but recently, 2 weeks prior to that precisely, he experienced lightheadedness and some loss of balance without loss of consciousness. And at that time, his doctor saw him and his blood pressure was started to be rather on the low side, 100/54, and his lisinopril was reduced by half. His blood sugar has also been found to be well controlled. Relating to his past medical history, he's known to have diabetes, hypertension. There's a possible history of a previous MI, myocardial infarction, but he and his doctors were not quite sure. And of course, he also had a family history of a mother that had myocardial infarction at 60 and a brother that died suddenly at the age of 48. How should we interpret this further information?
Now, with the additional history we have now, we have someone with significant history of comorbidities.
Okay.
And significant family history of cardiovascular disease. Now, the way we handle this now will now be different. Bearing the fact that this person has all this risk, family risk, cardiovascular disease. So the way we're going to take this history of collapse down is going to be more aggressive than someone without any of this history. And these are some of the things we're going to look into later in the presentation, that when someone comes with complaints of collapse, there are things we have to look into. There are important things we have to take notes in the history. History of comorbidity, significant history of cardiovascular disease in the family, especially the premature one. So these are some of the red flags that we are going to look out for before we discard, because I know a lot of us would have seen someone with, I just felt a bit lightheaded, but I didn't fall, I staggered a bit, and most of the time we wake them up, that patient has come again.
And I want to remind all of us that pre-syncope and syncope, they are actually one and the same.
Yeah.
It's just that the person did not fall to fall.
That's just the only difference
between them. That's one. And then secondly, regarding the low blood pressure or the relatively low blood pressure of 100/54, I know we all have patients that are hypertensive, that are on antihypertensives, and they have this dizziness, pre-syncope, and sometimes syncopal episodes, and we just attribute it to the blood pressure medication, even sometimes without doing adequate workup. Would you think that his internist did enough by just reducing his lisinopril at that visit?
Yes, that's part of what we'll also see later, that not doing your thorough examination
or evaluation
of the patient is a major factor that may make you to miss
the key points.
Important key point that will help you in clinching what the problem is in the patient. Because if the person had taken good history, maybe had checked the blood pressure in different positions,
absolutely,
he might have been able to get some further clue apart from just assuming that this problem is just due to the lisinopril that the patient is taking.
Okay, so in going forward, I think we'll just look at the examination findings of this patient at presentation, and we can see that the examination findings, his blood pressure was okay at 124/62, no postural drop in the blood pressure, and the carotid palpation was fine, the auscultation was fine, normal cardiovascular examination, we can see the bruise that the patient sustained. His labs were fine, and the ECG at a month before presentation was fine. The current ECG of the patient is shown on the screen. Now, we'll try not to bombard people with ECG.
Yes, so that we will not lose interest. We'll talk about the ECG later.
Okay.
So, but this is the ECG,
of the patient.
Of the guests.
Okay, so we'll just do a short poll now in terms of considering what we think about this case that was just presented. That was just presented. Okay, the diagnosis of this patient is most likely is thought to be syncope from too much hypertensive medications, and that's why the dose was reduced before. So in this case now, do you think, which of the following do we think is correct? Putting in the context of this ECG that is there.
I just want to ascertain our level of knowledge
and participation.
What do we think is wrong with these patients?
Okay, so just give us a few minutes to look at the poll. The poll should be showing on our screen now. We have this ECG during the supine and erect blood pressure check. The blood pressure was
And the assumption was that this is just due to
the light
blood pressure,
pressure,
and maybe some vasovagal attack. So,
okay, thank you for voting. We encourage people to just participate for a few more minutes, for about 1 more minute. Then, of course, we'll delve into the presentation, and then, of course, we'll reassess this along the way. Okay, so I think the answers are fairly tight.
yes.
We'll revisit this poll
later
in the presentation, and of course we are going to have the opportunity to vote again, and then we'll see how our voting pattern is changing. I won't share the results yet for now. Dr. Ladiko, what is syncope?
Okay. So syncope is a self-limited, transient loss of consciousness and postural tone as a result of global cerebral hyperperfusion.
Okay, hypoperfusion.
Yes. So the important keyword in this is one, it is transient.
Yeah.
I mean, just for a brief period. It is self-limiting in terms that there is prompt recovery, complete without any intervention. So that will help us to distinguish this syncope from other form of condition that will also result in the transient loss of consciousness. So the keyword, like we said, is transient, self-limiting. I mean, you don't need to do any intervention. There's rapid, prompt, and complete recovery. The underlying problem is global cerebral hypoperfusion, most of the time from drop in blood pressure of the patient. So that's the way we would describe a syncope attack.
So that would mean that the classic patient that has a syncope episode is a patient that was well or fairly well moments ago.
Yes.
The patient likely felt dizzy, fell to the ground, and then within seconds came up.
Yes.
Came back to his usual self lightly.
Yes.
Okay, so it's rapid, and of course you don't usually need any intervention to get the person back to consciousness. Okay, so that's I think that's the definition of syncope that we're using this afternoon, and I can see from the definition that we have here is just basically that transient state of consciousness that is due to global cerebral hypoperfusion.
Yes.
I think that global is important in distinguishing it from
some other condition. Example, like maybe a stroke or a seizure where you have focal issue and not a global issue. And like we said, there may also be some warning sign.
Yeah. Like
the patient presented as some numbness, some tingling sensation. There could be some warning sign that give the patient a kind of warning that this thing is about to happen. And that is important, especially in management, though today's topic is not all about management, because if the patient can recognize some of these warning signs, the patient can actually do some of the counter regulatory measure to prevent these events from happening.
Okay, so as we said, that syncope is generally self-limiting, but we just want to tease in that there's sometimes that people experience syncope in certain positions in which it may make it last longer than usual. So for example, if someone is seated in a certain kind of chair that you cannot fall to the ground, and because it's actually the falling to the ground
that will restore cerebral perfusion.
So if someone is in a certain kind of chair and then you cannot really fall to the ground and the head still remains above the body, then the perfusion will likely last longer. And it also happens in people with defecation syncope, in which it happens on the toilet bowl and then their head just remains like that at the back and they pass out for longer than they will have passed out. Okay, but generally speaking, syncope is self-limited. It's actually part of the core things that define it.
Yes.
Okay, so I think we're done with this part. Okay, so what's the difference between syncope and other causes of transient loss of consciousness?
Okay. Like we said, the first thing is syncope is transient.
Yes.
considering other form of transient
Loss.
loss of consciousness, for example, seizure, the duration lasts longer in those conditions compared to seizure. We talked about some
syncope.
Yes, syncope. We talk about some warning sign that the patient may see. In other form of loss of consciousness, you usually don't see this warning sign, and or some of these signs are very, very different. We talk about self-limiting, being self-limiting. In most other causes of transient loss of consciousness, you will need to intervene. For example, a patient who develops transient loss of consciousness from hypoglycemia. Until you correct that hypoglycemia, the patient will not get better. So that's another difference. Another difference that we can find based on some form is that you can have some history of some background condition, which you will not find. For example, a patient that developed syncopal attack as a result of maybe an arrhythmia or some other cardiac thing, you may have some information, some structural heart disease at the background, which you will not find in other form of transient loss of consciousness. So these are the major thing that differentiates a syncopal attack from other causes of transient loss of consciousness.
So syncope is a form of transient loss of consciousness, but there are many other causes of transient loss of consciousness that are not syncope. And I think that's one of the key challenges of the healthcare practitioners when we are called to see someone who has experienced a transient loss of consciousness. We often have to ask ourselves that, was it a syncopal episode or not? And when we don't recognize that it is syncope, sometimes it might make you subject someone to too much investigations that they don't need, perhaps even medications that they don't need. Then sometimes you may not do the intervention that you should have
appropriately.
And then the opposite can be more disastrous, actually. If someone had, for example, a seizure or something else that is more important. There's a patient that we're managing once. She's still very fine now, actually. But she has diabetes, but she had spells of passing out. She had spells of passing out a few times. We initially attributed it to hypoglycemia, but unfortunately, most of those times they'll just give her a bottle of Coke, they'll give her something sweet without even checking. And by the time they check later, they find out that the sugar was normal. So we assumed there was hypoglycemia for a long time until the spells got a bit longer and someone noted seizure-like activity on one day. And of course, further evaluation actually showed that this person was having a seizure episode. Of course, that transient loss of consciousness that she had would not pass for a syncopal episode, primarily because, of course, it was not self-limiting. The time she required drinking something sugary to correct it will make it not to be self-limiting. And of course, it tells us that even in ones that look like something, there may be a lot of other things that can look like it. Yes. And many times you actually have to take a good history, particularly from a high witness. But I'm sure we'll discuss all of that along the line.
Then I want to point out that we should not just look at syncope as a benign condition. Though the underlying cause may be benign, but the resultant effect of that syncopal attack might be disastrous. Like one of our patients that we just saw yesterday has had 2 road traffic accidents between November and March this year. And the only thing he could recollect from both accidents was that there was just a momentary loss of awareness, and the next thing is it was the sound of the crash. He's still undergoing investigation, and we don't know what the underlying cause. So even if the underlying cause is benign, but imagine a pilot having a syncopal attack in the air. So this is an important complaint that should be taken very, very serious. And you may actually need to give some warning or reports that for the period that this person is still undergoing investigation, you have to stop driving. That guy, I have to tell him that for now, you have to stop driving.
Operating heavy machinery and things like that will all have implications for that. So I think that's important. So before we go into classifying pathophysiology and evaluating syncope, how common is syncope?
In different studies looking at patient complaints, that about 20% of general population will make a complaint of a syncopal attack in their lifetime. But coming to emergency presentation, hospital, about 3% of patients that present to the ER comes with complaint of syncope episode or a pre-syncopal attack. And about 1% of them is admitted. And later we'll look at why you'll see some and you tell them to go home, and things you will see in some people and you tell them, no, I have to keep you for further evaluation.
Now I'll ask you that is syncope likely to be a serious issue in children or adults? Who is more likely to be a serious issue?
Syncope cut across all age groups, from the very young to the very old. And syncope attack occurring for the first time in a younger person is likely to be from a benign cause compared to a 65-year-old man presenting to you with his first-time episode of a syncope attack. Infrequent attack or a one-off attack is also likely to be benign, less malignant, more likely to be benign. But someone having a recurrent attack of syncope attack within a short period, you have to look closely at that person to make sure that you're not dealing with something sinister in the background. So actually, there is like a bimodal distribution. Late adolescents around 20-30 and from 60 years of age and above. And in those that are 60 years and above, you actually have to make sure that you rule out any structural damage to the heart and other heart condition in those age group. And another thing that also makes it a bit commoner in the age group is the problem they have with the autonomic dysfunction they have with age. Absolutely. So that's another thing that makes it common among that age group.
Absolutely. So it's more common in females. I think everybody will agree.
Yes.
So syncopal spells is more common in females, slightly more common in females. And it's just that from some research, it suggests as though males are more likely to have a more serious cause for the syncopal episode. That's one. And that's is thought to be likely due to the higher cardiovascular burden that males have. So in my mind too, out of all the syncopal cases I've seen maybe a bit more females than males. So I think it's just one of the things that we'll put in mind epidemiologically. So I think it's now time to talk about the classification of syncope.
Yes. Broadly looking at transient loss of consciousness, we can broadly classify them into traumatic and not traumatic. Traumatic, as we know, due to
concussion,
trauma, head injury, and all this stuff. And we should not forget that elderly people or people with dementia with Lewy body that are prone to fall can also have traumatic transient loss of consciousness. And for non-traumatic loss of consciousness, syncope is a major one, and the other non-traumatic cause of syncope that we talked about, seizure, electrolyte derangements, sleep disorder, alcohol intoxication, drugs, and all those ones. But looking at syncopal attack, the classification and pathophysiology are linked. So as you're talking about the classification, we'll also be discussing the pathophysiology.
Okay. So before you go on, I want us to actually go through these other non-syncopal cause of TLOS. Okay. So here on this slide now, you have epileptic seizures.
Yes.
You have the psychogenic ones, which can be very problematic.
Yes. And that is one of the reasons why syncope or collapse generally is more common in the female age group because of this psychogenic classification.
Absolutely. So we have the rarer but very important causes like the subclavian syndrome, the vertebrobasilar TIA. So we have that posterior circulation, CVAs, and that can be quite tricky many times.
That can be tricky.
Sometimes they present with just vertigo.
Yes,
absolutely. Okay, and then SAH sometimes can actually give part of the warning scores sometimes can be like transient loss of consciousness, which the person recovers, but if it's not identified and treated early, the person usually will progressively deteriorate. Okay, and then we have the epileptic seizures, all sorts of them actually, including the so-called drop attacks, in which the consciousness is actually preserved.
Loss of posterior tone.
So I think From experience, I think epileptic seizures are actually one of the strongest differential diagnosis of syncope.
Yes, that's one of the condition that makes it a lot difficult.
Absolutely.
For physician, that is this person having a seizure? Is it a temporal lobe epilepsy? Yes. Is it all this atypical seizure? Or this person is having a syncope? It's always a very great challenge to be able to
so facing syncope now, I mean, putting aside all other causes of TLOX, how would you classify syncope?
Okay. So, like I said,
just a moment, please.
Okay. So looking at classification, and like I said, as we're talking about classification, we'll also be talking about the pathophysiology of syncope along the line. Broadly, looking at syncope, we classify syncope broadly into three major categories.
Okay.
One is what we call a neurally mediated syncope or reflex syncope, which is the most common form of syncope, followed by the autostatic class of syncope and the cardiogenic. Like I said, the neurally mediated, or the one we call the reflex syncope, is the commonest. And the commonest in that class is the common vasovagal attack. Someone at the site of blood or site of an accident just dropped. That's the most common that most people will see. Under that classification, we also have the one we call situational. I woke up in the morning and I went to the toilet to pass urine, and someone just had
I've seen very
shouts from the
someone like the third
in
the bathroom.
In the toilet, pacifist lost consciousness after a bout of cough, maybe somebody blowing trumpet and whatever, I just fell during the service. So these are what we call situational, because we have triggers and other conditions associated with it. Then under this is the carotid sinus hypersensitivity, which can happen when you tie a very tight collar, shaving, abrupt
on the barber chair too.
Yes, trying to do this, then abrupt turning of the head. Then that is common, especially in elderly people. This one is common among male elderly patients. So these are reflex syncope, and the underlying pathophysiology is due to an exaggerated parasympathetic activity with suppression of the sympathetic vasoconstriction that happens. So due to any of these, maybe vasovagal, the person has been standing for a while, or any of these situations, what happens is there is like a transient drop in the venous return due to blood moving from the thorax pulling towards the lower side of the body. So there's some reduction in the venous return, and this leads to the bioreceptors in the carotid sinus, aortic artery, they sense this, and there's increased sympathetic release to help to correct this. But for the heart that is underfilled, the sympathetic activation will lead to increased contraction of this underfilled heart. And this leads to stimulation of some mechanoreceptors in the heart muscle. These mechanoreceptors are the ones that are now like overdrive suppression of the sympathetic system and now activates a parasympathetic symptom, leading to either a cardioinhibitory reaction where you have like slow pulse, or can be as bad as the patient having a sinus pulse or asystole. Then there could be a vasodepressor effect where the blood pressure drops, leading to the patient now dropping. And while the patient drops because of the loss of postural tone, gravity helps and cerebral circulation is restored, and so quickly the patient wakes up. So that's why it is transient and it is self-limiting. So that's the reflex syncope for you. So the next group is the group that we classify due to autostatic hypertension. And primarily, the underlying factor here is autonomic failure.
Absolutely.
Inability of the autonomic system to be able to restore, because the postural change also leads to pooling of blood. So the next thing is for the autonomic system to kick in, vasoconstriction, restore blood flow, and the BP also goes up. That's the normal thing that should happen. But due to so many issues, maybe it could be due to primary autonomic failure in patients with multiple system atrophy, patients with Parkinson that has a primary autonomic dysfunction, or it could be secondary to condition like diabetes, peripheral neuropathy. It could be drug-induced, and it could be as a result of volume depletion, like a patient that has lost blood from hemorrhage or dehydration. So, what happens is the patient moves from a supine position, stands, and it could be immediate and it could be a bit delayed, and the patient just fell like this and the patient drops. And once the patient drops, the loss of postural tone, gravity, everything comes back and the patient is fine. So that's the autostatic hypertension group.
So the vasodilators, things like amlodipine, things like our nitrates,
hydralazine, nitrates, all of them.
PDF inhibitors, all of them can cause vasodilatation. And the diuretics, apart from some vasodilatation, it causes also volume depletion as well. I've seen with phenothiazines a bit, okay, and then of course you know that even people with volume depletion also from, apart from the diarrhea, vomiting, hemorrhage, also from polyuria and people with hyperglycemia can also experience the autostatic hypertension. And it's important to recognize this because just simple measures can actually can correct this and make the patients less likely to experience it again. I can see in the notes here that hypertension can be can be worsened by venous pooling during exercise and
because of the vasodilatation that happens.
Absolutely.
And after meals, all these things.
So I'm sure we've seen patients that experience some form of dizziness after meals. It's related to that, even though the what we call that dumping syndrome can be a mechanism in certain patients. So the prolonged bed rest is also important, and it's part of the things we talk about when we're talking about checking autostatic checking blood pressure supine and erect. If someone has actually lied down in bed for a long time, there's the conditioning of the autonomic response is the condition, and that means the person may not be able to. It may take a while before the person gets that reflex correction when the person stands up. Okay, so what are the cardiac parts?
So the cardiac syncope is subdivided into three again. It could be due to arrhythmia. It could be due to other structural heart disease. Then it could be due to some other form of cardiopulmonary problem. Under arrhythmia, we talk about abnormality in the rhythm of the heart. It could be due to a slow rhythm. It could be due to a fast rhythm. That means it could be due to a bradycardia in patient that has atrioventricular block, patient with sinus pause, sinus arrest. It could be due to tachycardia, different form of supraventricular tachycardia, ventricular tachycardia. But it should be noted that atrial fibrillation alone will most likely not precipitate a patient to a syncope attack. But atrial fibrillation with slow ventricular response or with associated sinus node dysfunction is what may precipitate syncope in the patient with atrial fibrillation. Therefore, those with other structural disease outside arrhythmia, patients with hypertrophic cardiomyopathy is an important that particularly we should not. Yes, and especially in young active people. So a young man, athletic, having a syncope attack while doing exercise, please take that person very, very serious and screen for any structural heart disease. Then the cardiopulmonary, we talk about patients with pulmonary embolism. They can present with syncope. Patients with aortic dissection can present. So these are the group we put under cardiogenic syncope. And looking at the three groups, the cardiogenic syncope is the one we refer to as the malignant form syncopal attack. So a patient with syncopal attack and with any suspicion of any cardiac abnormality should be taken very, very seriously. While we are looking at a patient with a reflex syncope or with autostatic hypertension, we may still be a bit lenient in looking after the person.
Thank you, Dr. Alekon, for going through all those parts very detailedly. So here we are. I think we've talked about some of this to a variable extent. So
just emphasizing.
Absolutely. The intoxication part is actually quite interesting to me because we've actually seen, well, there are still transient loss of consciousness. I remember the time, maybe about, I think it was sometimes last year, that a young man was brought, she was a driver to a lady. The man brought her in to the hospital that, okay, this is my driver, but he just met him on the floor. The guy was actually, he took some substance, it's not alcohol, but he took some substance that made him like literally pass out. And he was brought, of course, after about 2 hours, the guy recovered consciousness and just was aggressive to go home. Like, just wanted to leave. So quite some number of intoxication can actually cause some transient loss of consciousness. But most times, those are not things we can mix up with syncopal episodes. Cataplexy is also very interesting to me.
Sleep disorder,
In fact, the person you described with the driving, that crash during driving, because that's actually a bit unlikely to be syncope. Okay, so someone driving and then crashing. We know cataplexy is a condition in which sleep just catches the person forcefully and immediately, and of course the person sleeps. It's actually part of that.
Yes. Then we should also not forget patients with obstructive sleep apnea. Because of the frequent apneic attack during the night, so they sleep a lot of narcolepsy during the day. So, and that's why we need to comprehensively evaluate this patient, and we should also not forget the behavioral physician in this, because this is totally encompassing. Because for a patient having recurrent syncopal attack, even if it is benign, it is a great burden on the affected patient. So we should not just handle it lightly, because that's one of the things we most likely is that nothing, just go. So we should take it as something that we need to really look out for. And another thing, like we said at the beginning, is syncope is a symptom. So we have to look for what is causing it.
It's not a complete diagnosis. It's not even a diagnosis by itself. Okay, so we have this beautiful chart here. Dr. Can you elaborate on this chart?
This chart just totally cover all we talked about during the pathophysiology. That the key problem at the middle, at the center of syncopal attack is cerebral hypoperfusion.
Absolutely.
From low blood pressure. And if we go back to our physiology, we know the factor that drives blood pressure are the cardiac outputs and the peripheral resistance. Absolutely. So it's either you have a low cardiac output or you have problem with peripheral resistance in terms of vasodilatation, with pooling of blood. So looking from the direction of the low peripheral outputs, it could be from the reflex side due to that parasympathetic and loss of vaso constrictive effect from suppression or withdrawal of the sympathetic activation. And so you can have a vasodepressor effect from patients with vasovagal attack, situation syncope, carotid sinus hypersensitivity. It could be due to autonomic failure, like we talked about, which could be due from drugs, from secondary conditions, from primary autonomic failure. And it could actually be due to maybe pooling of blood from hemorrhage, dehydration, effect of diuretic and diuretics. That's why all those ones cut across low peripheral resistance. And looking from the low cardiac output aspects, reflex syncope can also cause that when patient has cardio-inhibitory reflex action, where the patient has asystole. So that can lead to, because your cardiac output is also a product of your stroke volume and your heart rates. So, and for cardiac syncope, arrhythmia, structural heart disease, patient with aortic stenosis, atrial myxoma, hypertrophic cardiomyopathy, when you need them to increase cardiac output, you have obstruction in one way or the other, limiting your stroke volume.
It's quite painful that many of these things are actually missed. We doctors, we miss a lot of these things. And I've seen a lot of patients, I would say that most of the aortic stenosis patients I've seen were diagnosed outside the country, for example. So we miss, and that, because many times we try to explain things away with little convenient things for our own convenience, and maybe in our mind also for the patient's convenience. I will go back to the case we discussed earlier. I mean, the patient has those kind of risk factors. The blood pressure was like that, and then we just attributed the person out to
Syncope and just have the. So that's one of the reasons why we brought this up, because most of the time we trivialize this complaint, and it's just a symptom of something sinister, or maybe it's just a warning that could have led to discovery of something significant, maybe in the cardiovascular system or not. So it's something that we should patiently explore, so that we will not be missing out something very important that can affect the patient negatively later. So this is what this chart is about. So if you look at this chart, it gives you all the classification, and it gives you the underlying pathophysiology for physiological mechanism.
Okay, so I think we have one more slide on the pathophysiology of
okay, this is just explaining everything.
The triggers. So there are many
triggers, looking at what I've explained about the mechanoreceptors, the afferents going to the nucleus solitarius in the brainstem, and the efferent through the vagal nerve, parasympathetic activation, and all the rest.
If we remember the function of the vagus nerve in terms of relating to the heart rate, one in terms of vasodilatation and vasoconstriction, and then if we look at all the other connections it has, both in the brain and the level of the hypothalamus and the limbic system, both also in the somatic and visceral system, then one will actually be able to understand why micturition can cause syncope in certain people, while swallowing can cause swallowing, etc., etc., etc. So I think this is a good chart for that. So again, back to the epidemiology now. Out of all these classes you gave us, which would you say is the most commonly found cause of syncope? Is it the vasovagal? Is it the cardiac? I think we mentioned it earlier, but I wanted to reiterate
the neurally mediated syncope is the commonest type of syncope, both in the general population and even in the hospital.
Okay, so that's the reflex syncope.
Yes, that is the reflex syncope. Is the commonest.
It's the commonest, okay.
And followed by both the cardiac and the autostatic. It is a bit difficult to say which one is more. They are almost from all the different studies, but the commonest, like we say, is reflex. And we should not forget that about a third of patients with syncope, you will not be able to explain what the cause is. So that's another great challenge for someone just coming to you and you're not able to say this is.
And I think as physicians, we should be willing to say that your syncope is unexplained after doing all this work, rather than just attributing it to vasovagal, even though it doesn't fulfill the parameters to suggest for vasovagal. So I think the history has a very large role to play in.
The history is the most important aspect of diagnosing a patient with syncope. Because before you can say that a transient loss of consciousness is due to syncope, you must be able to ascertain some history that is associated with that syncope. Until you are able to establish that, you cannot conveniently say that the transient loss of consciousness the patient had was due to a syncope attack. It is better to say it is non-explained. So history is very, very important. If we are able to get a good history plus some things in the physical examination, about 50 to 60% of the diagnosis will be made, and we may not need to do any form of investigation for the patient. And taking history include taking history from both the patients, if you are fortunate to have an eyewitness, and in extreme case, you may even have a video evidence for someone, maybe somebody around, and he was able to capture the whole thing. That will help you a lot to achieve your diagnosis. So history is very, very, very important.
So what would you say about many of my patients that would not want to bother to give you history and just say, doctor, can't you just do all the tests and tell me what is wrong with me?
Both, all cardiovascular bodies, both in Europe, American, Nigeria, everywhere, has not really found evidence to suggest that any particular investigation is the gold standard for diagnosing syncope in any patient. So the emphasis is still on taking some important factors in the history and getting some things in the physical examination.
So what should we be looking out for in the history of someone that is having syncope?
The history starts from the way we used to say national name, age, sex, occupation. Starts from there, right from you want to know, ask question about one, onset of this condition. We talked about it earlier that, okay, someone having a syncope attack for the first time at age 65 or 70 is different from someone that has been having a syncope attack from like age of 15. Maybe the first episode was 15, then the person didn't have another episode until maybe 30. There are two different cases. The person that have his syncope attack starting earlier is likely to be a benign form of syncope attack, maybe a reflex syncope or an autostatic hypertension induced syncope attack, compared to someone having a syncope attack for the first time at the age of 65. Number two, looking at prior symptoms or warning symptoms. Patients with vasovagal attack usually have some warning symptoms: lightheadedness, feeling of numbness, feeling of warmth, diaphoresis, they can feel warm. So if you have those symptoms, yes, you will say, oh, most likely this is a vasovagal attack. You want to know what the patient was doing
At the time.
At the time. I was passing urine in the morning, maybe patient had cough, patient was eating, those are history that suggests a benign form of syncope attack. Someone having syncope attack at supine position or sitting is likely due to a cardiogenic syncope. Please, let's know that. Syncope attack in supine position or sitting position is most likely due to a cardiogenic form of syncope. While patient standing, immediately after standing, or maybe about 5 minutes to standing, we likely have an autostatic hypertension.
I would also like to emphasize that getting an eyewitness history is actually critical.
Very, very important.
Sometimes, I mean, in my own experience, I've had to actually speak to eyewitnesses on phone before. So I've had someone that the person that saw what happened was actually an office mate. Can you call the person on phone? Can I talk to the person? And then usually you get more information, because don't forget that by definition, if someone was unconscious when something happened, a person was unconscious.
Yes.
A person cannot give you
any information about
even
what
on
happened.
the duration and everything the person says. You have to actually take with a pinch of salt. So we have to aggressively try to find out, try to get information from
from
a eyewitness. Also, the state of the patient, even days or hours before it happened, can give you information whether there's a pre-existing illness or not. Okay, so someone that has been having chest pain for a few days, or been having shortness of breath for a few days before finally passing out like that is different. And of course, the things we have to ask the eyewitness, number one is the duration for which the person was out for, the kind of activities that was noted
during that episode,
whether when the person was passed out, whether there was jacking of the limbs, whether there was rolling of the eyes, whether there was twitching, how long incontinence. So we want to hear those kind of things. And it's also very important for us to get the history of the recovery, what the recovery was like. Did the person just wake up after a few seconds and was embarrassed that, what happened to me? Or the person wake up and was still stretching and yawning and was disoriented for like
10 minutes.
Absolutely. What was the post-ictal phase like?
Yes.
So those are very important. And of course, the past medical history is extremely important.
Extremely important.
Okay, previous history of syncope, things that can suggest structural heart disease, for example, cardiovascular risk factor in the person.
Yes.
So that's important. Is the person on any medications? that can always be a trick thing. Sometimes you flag a patient with syncope for a long time, and the patient just tells you that, but I just started lisinopril 2 days ago.
Yes.
So the issue of medication use
is very important.
Both orthodox medication, over-the-counter medication, and even herbal mixtures is actually very, very important.
A lot of herbal mixtures packed with vasodilator agents.
Absolutely. Okay. So, and then of course, family history is very important. Family history is very important because if there's family history of cardiac disease or sudden unexplained death, if you're asking about sudden unexplained death, you should ask carefully. Usually I describe it as death, any death that was unexplained, especially someone that was younger than 50 years old, can be suggestive. But of course, history of diabetes, in females, whether or not they could have been pregnant, there's a joke that is often said in medical school that if you see a woman in reproductive age slump, that is ectopic or otherwise probably. So whether they could have been pregnant and they could have been hemorrhage and all of that, so is something that you should find out in the history of the person. So I think those are all key historical points that we should put into consideration when we are seeing these patients. But of course, apart from getting a very good history, we should examine the patient very carefully.
Definitely.
So what are the things that would suggest a vasovagal syncope in the history?
In the history, we talked about warning sign, positioning. Those are very, very important. So warning signs, positioning of the patient, and some activities that patient is into before the. So if you have this history, very highly suggestive of vasovagal.
So the classic prodrome is thought to be the dimming of the vision, pallor, sweating, lightheadedness, feeling like vomiting. Usually, actually, they know that they're going to pass out.
Yes.
So there's that few seconds of saying that I'm going to pass out. Some people actually say that before.
Yes,
before
and that's why once you know that, they will teach them all those counter mechanism to make sure that you'll be able to prevent the attack from happening.
Okay, so of course there's a situational one that we've described, and I think we've described the orthostatic one to a great extent. The most important thing about the orthostatic one, by the time you get history of dizziness, pre-syncope or syncope in everybody, you usually will have to ask when you get out of bed, particularly in the morning. That is usually the weakest time because they've lied in bed for a while, and then the autonomic system has rested or has been subdued for a while.
So that sudden change
can give it away. So if you get dizziness that happens within minutes or within seconds of standing up, is oftentimes orthostatic syncope. Of course, we need to examine to document that this person has postural hypotension. So what ECG features?
What clinical talk of ECG features? Let's talk about the
examination finding.
Examination. Right from checking for pallor.
Yes.
Because like we talked about, blood loss can be a cause of syncopal attack, both in terms of reduction of the cardiac output and the other. So check, is this patient pale? Is this patient febrile? Some febrile condition can actually be like a warning, can even precipitate the patient to having a syncopal attack. So everything in general examination is important before you now go to say, okay, let me settle down on the cardiovascular examination. Starting from your pulse, the pulse rates, the reading, the volume, everything you checked in the pulse is very important. Does the patient have bradycardia? Does the patient have tachycardia? Is there any form of arrhythmia? Is there anything suggestive of aortic dissection, subclavian still syndrome, any differentiation in the pulse in the arms? So all these are important before you move on to check your blood pressure. And the blood pressure, I know the way we were taught in medical school is when you want to check your blood pressure, check both arms, at least 2 positions, and this is still valid because if we don't do this, we will actually miss a lot of patients with orthostatic hypertension. And not that we have to do it, but we must do it well. And the way to do it is, 1, your patient must rest for about at least 5 minutes, if I'm still correct.
Absolutely.
Check your blood pressure while the patient is sitting or in supine position. Then ask the patient to stand. So once the patient stands, first minute, check your blood pressure. After 3 minutes, check your blood pressure. And what are we looking for? We're looking for a significant drop in the blood pressure. Greater than 20 millimeter of mercury in the systolic blood pressure, greater than 10 millimeter of mercury in the diastolic blood pressure. And for those that have low BP, maybe around 110, 100, okay, if the systolic blood pressure is less than 90 millimeter of mercury, is also suggestive of orthostatic hypertension.
Apart from the drop in blood pressure, does a rise in pulse alone count?
Yes. A rise in pulse alone is not sufficient enough, but you can also have a rise in pulse of between 10 to 15, not more than 20, because there is a close association of this in what we call the postural orthostatic tachycardia syndrome. There, what happens is you have minimal or no change in the blood pressure, but you have an exaggerated increase in the pulse rates, greater than 30 from the baseline, or the absolute pulse rates higher than 120 beats per minute. So we must take that into consideration.
Okay, that's a good one. Apart from the examination, any other key things that we need to look for in the examination, apart from those cardiovascular examination findings that you talked about just now?
Looking at the heart, make sure you auscultate the heart. You will be able to pick murmur of aortic stenosis, signs of left ventricular hypertrophy, and other things that will point you to the fact that there's an underlying structural heart problem. Basically, that is what you need to do. But if you see the patient that just had a syncope attack, you must be able to look well. You'll be checking for signs of injury. Someone that had a syncope attack with injury in the tongue, we most likely suggest a seizure attack and not a reflex syncope or one due to orthostatic hypertension. Then, like I said, someone just fell, there could be a head injury. There could be some other form of injury, like the patient that was presented had bruises in the hip. We've had people that had syncope attack and sustained fracture of the neck or femur. So our examination should be all encompassing.
And of course, looking for symptoms of dehydration, etc., can also be important in certain people.
Yes.
So I think that's a good one. So of course, there's always definitely a need for a brief neurological examination.
Yes.
Particularly if you know that things like seizures and even cerebrovascular disease are differential diagnosis, we want to be able to pick other things that can corroborate these possibilities in the patient. Okay, so I think in summary again, we've said that in the clinical examination of a patient that has presented with a recent history of syncope or collapse, it's critical enough to examine the cardiovascular system, particularly the pulse, the BP, both in sitting and both in supine and in standing position. And of course, we should also auscultate the heart and examine the precordium, looking for evidence that can suggest structural disease, like things like aortic stenosis, ocum, and other things that can give us those kind of changes. It's also critical to do at least a brief neurological examination to look for focal neurological signs, which we can't go into in this presentation.
Yes.
Of course, I also did mention to look for features of hypovolemia, which can show us a low pulse volume or dry mucosal membranes. So apart from those, what investigations should we do for these people?
So after this, the most important investigation that we should do is to ask for an ECG.
Absolutely.
So you take your history, do your physical examination, then ask for at least a 12-lead resting ECG to look at what is happening in the heart. And any form of abnormality, we have a whole gamut of things. Once you get an abnormal ECG in a patient with syncope attack, please, you have to investigate the patient very, very well. Apart from maybe first degree AV block, any other abnormality you find on ECG is an indication for proper cardiac evaluation of that patient, starting from second degree AV block, especially the type 2, third degree AV block, any form of right bundle branch block, left bundle branch block, hypertrophy, presence of Q waves, arrhythmias. We have to, including profound sinus bradycardia.
Absolutely.
We have to make sure that we pursue the other important investigation to make sure that we resolved what is happening to that patient. And this is just showing what we have in patients with autostatic hypertension, which we have explained earlier.
Okay, so that's fine. So
maybe we just look at just shows people some of those ECGs that we have. This is a patient that had this ECG patient had first degree AV block. And
absolutely.
What we have in first degree AV block is a prolongation of the PR interval. I don't know whether.
Let me find the pointer. Let me find the pointer here to use. Let's just see. Okay, so prolonging of PR interval. You can see the PR interval.
Let's use the 2.
So let's use the 2. You can see this PR interval coming from the beginning of the P wave, and then to the end of the P.
To the beginning of the QRS complex.
To the beginning of QRS complex. Sorry.
So ideally, it should not be more than one big box. One big box.
So your hand is sitting. So it should not be more than one big
box. Here we can see like almost 2.5
big boxes.
Big boxes.
Okay.
Yes, that's so we can see almost 2.5 big boxes. So this is a patient with significant prolongation of the PR interval. So patients like this, what they are prone to is they are prone to atrioventricular desynchrony, because the prolonged PR interval is disturbing the normal transmission of impulse from the atrium to the ventricle. So it's like the two of them, they are not working as an effective unit, which can effectively reduce the cardiac output of that patient. So this patient can just drop and you have something like this. So you should look inward.
Okay, so let's see one or two other ECGs that we should be concerned about in someone that is presenting with syncopal episodes. Excuse me. Clear this thing. Clear. Okay, so here we go.
Okay, this is an ECG showing us second degree AV block. Maybe 2 second degree AV block. What we have is there is constant PR interval. PR interval is not prolonged here, but what we have is we have P wave with conduction going to the ventricle. Then suddenly you have atrial contraction that does not transmit to ventricular activation. So absolutely. What we have here is if you look at 1, 2, 3, 4.
Let me use this.
Let's use the arrow again to just show our people what we're talking about.
So here we go.
Let's start from this one. Here you have the P wave, you have the QRS. So you have the atrial contraction, ventricular contraction, atrial contraction, ventricular contraction. Here you have a P wave. The next thing should be a QRS complex showing you a ventricular contraction, but that is not found here. Then it goes back. So what you have is just suddenly there's a P wave that is not conducted. So for that bit, effectively, there's no ventricular contraction and there's no cardiac output. Now imagine the one under it where you have it occurring in successive beats
until you have a
ventricular contraction. So these are patients that you need to take a very closer look on and take important decisions.
Okay, so I think we'll just go through one more ECG. I think there's the last ECG. Oh, I didn't get the annotations. Okay, so
just showing that this patient had a profound sinus bradycardia. If we look at this heart rate here, I can't even imagine what the heart rate of this patient will be.
300 divided by
almost 20, maybe 15 beats per minute.
15 or 20 beats per minute.
Imagine someone's heart beating 15 times in a minute. So how will you compare the amount of cardiac output of that
and
patient.
this syncope is more likely to be during exertion here now,
Yes.
because the heart rate of 20 beats per minute maybe may be able to sustain the person while sleeping, but definitely cannot sustain a walk.
And thank you for bringing that up. During the history, another important thing we should not forget is to ask whether the syncope attack occurred during an activity or after. Because syncope attack during exercise is suggestive of a cardiac syncope, while the one maybe before or after is most likely due to a reflex syncope. So that information, that single information, is very, very, very crucial.
Okay, thank you for bringing that up. So, what patients need to get echocardiography?
Any patients that are suspecting cardiac syncope must do an echocardiography. But I will say, in our environment here, where we are limited in a lot of things, don't have enough history, no eyewitness, I will say every patient with syncope should do. I would say every adult patient with a syncope attack should do an echo, because echo might be the only opportunity you have to get some of these underlying diagnoses. There is one of our patients that came into the hospital on his own. The only thing he just said was that he just felt that he's not feeling too fine and not active like his other friends. And lo and behold, by the time we did the echo, it was classical hypertrophic cardiomyopathy.
Wow.
So if not for that opportunity, he has gone all around. He just said someone sent him here to come and do an echo. And when he came and said, that is strong, but by the time we did the echo, it was classical hypertrophic cardiomyopathy. So I would advise that everybody, but more especially, like I said, people with syncope attack, where you can see findings suggestive of atrial myxoma, aortic stenosis, hypertrophic cardiomyopathy, and other important issues.
I will also say older patients, particularly people that are already above 40, where cardiovascular disease burden is already a bit higher. And then for everybody, before you tag any syncopal episode to be unexplained, one should actually get an echo to actually look at the structure of that heart. Because we should not forget that when we say there is cerebral hypoperfusion, perfusion is coming from the heart through cardiac outputs. So it is somehow, to say the least, not to look at the heart if someone passes out.
Your examination and investigation is not
complete
yet.
Okay, so but for based on this guideline, these are things that should make you. These are key things that we look for when we're doing the echo for this kind of people. Aortic aneurysm, plus or minus dissection, pulmonary embolism, aortic stenosis, atrial myxoma, and things like that. What blood tests would you consider in someone that has had the syncopal episodes?
Like we mentioned earlier, the key part of the evaluation is the history, physical, and physical examination with your ECG findings.
Absolutely.
There's no blood test really that you will say will help you, but the blood test you ask for depends on things you get history and other situations. Maybe a patient with bleeding, like we talked about, someone with ectopic pregnancy, you want to do your ECG,
absolutely. So I think that it depends on the situation, like you said.
Depends on the situation.
So for young females, for example, it won't be out of place to ask for a pregnancy test or a beta ECG. That's one. For many other people, it's a good idea to do a full blood count to see anemia, because I've seen people who have been having dizzy spells or syncopal episodes. Actually,
and nobody does bother to ask for a PCV.
Absolutely. There's a lady I saw maybe up to 2 months ago. She had been having, she didn't have syncope, it was palpitation she was having. She had done ECG, thyroid function test, ECG silent tachycardia. PCV was, by the time I saw her, PCV was about 16%. She was having menorrhagia from fibroids. Okay, so anemia can actually cause syncope, and it's something that, of course, by the time it will be bad enough to cause syncope, you should be able to pick PAL on physical examination. Okay, then for arrhythmias, for all arrhythmias, almost all arrhythmias can be worsened by electrolyte derangement.
Yes.
So
then we should not forget troponin.
Absolutely.
The patient you're looking at myocardial infarction, because myocardial infarction leading to scar in the heart may actually be the underlying cause of arrhythmia. Okay. So then D-dimer.
Absolutely.
In patients you're suspecting maybe is a pulmonary embolism and all those ones.
Okay, and then the electrolytes should often include calcium and magnesium when possible.
Yes.
But particularly if you pick some arrhythmias there.
Yes.
Okay, so I think those are things that are likely that can be fruitful in terms of investigation. What other investigation? So we did mention this now here: the hematocrit, troponin, the D-dimers, and of course the electrolytes as well. Okay, so what other evaluations is going to be very important for these patients?
Other evaluations, like we said, now depends on other associated condition that the patient is presenting with. In patients presenting with arrhythmia, palpitation, with syncope, you want to ascertain what the rhythm abnormality is. Okay. And depending on the frequency of the symptom that the patient will have, that is what we determine what you will ask for. So that is why how we now got into the era of ambulatory ECG monitoring. Okay. So that is very important. So like in our environment here, you want to do an Holter for these patients. At least in 48, between 24 to 48 hours.
Why is the Holter? What if the resting ECG? I know some people will say that if the resting ECG was normal, that you may not necessarily need to do an Holter. What advantage can an Holter give us?
Because like we know, most of this arrhythmia or rhythm of the heart are paroxysmal.
Absolutely.
By the time you are doing a resting ECG, which is just maybe less than 10 seconds, you may actually not see any of this. We had a patient that came, the 12-lead rest ECG was perfectly normal. And by the time she did a 48 hours Holter, what we had was premature ventricular complex, couplets in bigeminy throughout. Wow. So there's no way that patient will not have syncope attack because of disruption, because of the abnormality in the rhythm. So it is not enough to just do a 12-lead resting ECG while not going for an ambulatory ECG.
Especially if someone that is older, someone that has cardiovascular risk factors, or someone that's had a syncope episode more than once. And then sometimes, even in a low-risk person, you may just want to evaluate thoroughly.
Yes, thoroughly. And another ECG that we should also consider is the stress ECG. Because like we said, attack happening during exercise is a malignant form of syncope that we must look into so we may need to simulate this activity under well-supervised condition. The doctors must be available. Every possible resuscitative measure should also be made available. And you put these patients on the treadmill. You may be able to elicit symptoms, or you may be able to elicit some of these fatal arrhythmia even in the absence of symptoms. So you put someone on stress and you're now saying advanced second degree, third degree AV blocking, even when the patient is normal. Please stop that test and do something for that patient.
It was in the news recently of a doctor in, was it Italy or somewhere, that was sanctioned for not evaluating someone that just a footballer, I think.
Yes,
that had some minor, so apparently minor red flag signs, but it did. So I think it's good for us to look thoroughly, actually. Yes. Particularly, we know that the emergency response system in Nigeria is not as robust as it should be, and then we have all the sudden cardiac deaths happening all over the place. So I think it's a good idea to evaluate these people very well. So you talk about the Holter monitoring, which can be done for 24, 48 hours. I know in certain places they do up to 1 week.
Yes, even up to months, where the facilities is available by putting an insertable loop recorder, can be there up to months for people that have very.
I'm sure most of my patients will not agree to that one putting there for months anyway. But yes, it's applicable in certain situations.
Yes.
I want us to talk a little bit about this head-up tilt tests.
Yes, in patients when you have done, you are taking your history, you are not certain, you've looked at the heart, the heart is fine, no history suggestive of any underlying cardiac problem. Okay, you now still want to ascertain what is the underlying cause of the syncopal attack of this patient. So you can now take those patients for an head of tilt table test.
Is it a risky test?
It's a risky test.
Oh, yeah.
It's a risky test because you want to try to bring up symptom, and if you are not careful, especially in some patients with past history of myocardial infarction, stroke, you might actually cause a lot of problems. So it is done, like we said, under supervision. All the facilities available are available for resuscitation, and your equipment is working. The tilt table is designed in a way that you can quickly bring the patient back into a supine position within 10 seconds once you are able to get the result you are looking for. So what is done is the patient comes into the room, placed on the tilt table test. You allow the patient to lie supine for about 5 minutes, take your blood pressure, take your heart rate, and after that 5 minutes, you raise the patient to between 60 to 70 degree upright position, and you observe the patient for about 20 minutes. What you are looking for is to be able to elicit the symptom the patient is having, and that is when the test is more sensitive and specific, when you are able to elicit the symptom the patient is having alongside changes in the blood pressure and the heart rate of the patient. If you're able to elicit the symptoms and the patient is able to say, this is what I feel, you've gotten what you need, and you take the patient back. But if after 20 minutes, there is no symptom or there's no significant change in any of the vital signs, you can do some provocation using either isoproterenol or using nitroglycerin to still challenge.
So which patients? I know we don't do tilt test here yet. I hope we can do soon. But which patients ideally will benefit from these tilt-up tests?
Patients with vasovagal form of syncope, patients with autostatic hypertension, and it will also help you to be able to tease out patients with pseudo syncopal attacks. Absolutely. Because what you find in patients with vasovagal hypertension is during the tilt table test, the blood pressure drops. The blood pressure drops. The heart rate may increase minimally. Okay. Then the heart rate also drops. That is the normal. This is the normal tilt table test. The heart rate, by the time you tilt the patient up, the heart rate goes up and the blood pressure also goes up. That's the normal response. In patients with reflex syncope, you can have a slight increase in the heart rate, but the blood pressure drops. So this is at the patient we have symptom, and by the time you restore the patient back to supine position, everything comes back to baseline. So that's your patient with but in patients with autostatic hypotension, in the classical one, that is the one that is the immediate autostatic hypertension. Like after the first minute, the patient starts feeling symptoms. What you have is the heart rate might remain normal, or you can have a slight increase in the heart rate due to the sympathetic activation. But what you see is that's 20/10 drops in the systolic over diastolic blood pressure within that short period. That's your classic immediate autostatic hypertension. In the delayed type, what you find is you still see the same change, but it takes a while before you notice that significant change.
So what's the clinical significance of
the clinical significance of this is the ones with immediate, it stands up, it feels it can actually hold something, sit down or wait for a while for the system to regain its balance. But with patients with delayed autostatic, the patient is already in motion, is not aware, and this person can actually fall and sustain very severe injury. So that is why this delayed autostatic hypertension is more dangerous than
the young lady I saw recently. She had syncope of mixed origin actually, but she did have some autostasis on examination. So the most severe episode she had was the one that she crashed into their central table at home, and she actually broke the table. So I think she had worked for a while, and she said she felt she could still take a few more steps. The next thing she remembered was that she was being resuscitated at home. She was on the floor, she had broken things on the table, and etc. etc. So I think that was like a delayed one, so to say. So I think
let's just talk about our psychogenic people.
Oh, yes, please.
So after the tilt,
yes,
the patient is having the symptom, but the blood pressure is up.
Oh yeah.
The heart rate is also up. So you know that this one is psychogenic.
Okay, so the tilt up will actually.
So the tilt test will help us to tease out some of those clinical conditions.
Okay, Dr. Aliko, thank you very much for that. We need to really rush now so that we don't abuse people's time. I'll just ask you that which other investigations is important in a patient who is presenting with...
Yes, doing ambulatory blood pressure monitoring is also relevant in this group of patients, because we talked about patients with autonomic dysfunction as one of the major cause of autostatic hypertension. So doing your ambulatory blood pressure monitoring will help you to identify patients in this group, because this group of patients they have what we call nocturnal hypertension. The nocturnal hypertension.
Okay.
Because the normal blood pressure profile or the pattern should be you have the higher blood pressure in the morning because of the counter-regulatory hormones, and the blood pressure comes down. And actually, we have what we call a dipping status. By the time you consider the day blood pressure and the night blood pressure, the difference should be between 10 to 20, about 10 to 20%. So your blood pressure during the night should be lower than the blood pressure during the day. But patients with autonomic dysfunction, what they have is either a non-dipping or a reverse dipping. The meaning is that the blood pressure does not go down at night. So the blood pressure is almost the same. So that patient has a non-dipping pattern, or the blood pressure at night is actually higher than blood pressure during the day. So that is reverse dipping. Your blood ABPM will help you in that. ABPM will help you to diagnose hypertension during activity or after meal. Patient with situational syncope. If you are on ambulatory blood pressure, you'll be able to establish this blood pressure difference in this group of patients. And also following administration of drugs. So say, is it really due to drugs? Okay, let's check what the blood pressure looks like.
We've seen the truth is that when we give antihypertensive medications, the way patients react to them is actually quite different.
Yes.
So we have a lot of patients that, if you look at their 24-hour blood pressure pattern, like there's someone I saw in clinic just now, his own readings, a lot of his own readings are actually, BP is actually very uncontrolled. But the reading in clinic today was like very good. And I think the way his body responds to the drug, he uses the drug about 8 a.m. in the morning. He says most of the time when it comes to clinic, it's around 12 p.m. So most of the time around 12 p.m. BP is actually probably quite good. And then later in the evening, the BP is already back to high. Early in the morning, the BP is very high. So such person, for example, let's say his BP was already well controlled around 120/80. It means that at least on that current medication, the BP will probably go low around 12 noon. And it may be difficult to corroborate that if I don't have something that is like an ambulatory blood pressure profile. So in someone that has postural dizziness or any kind of dizziness during the course of the day, there may actually be a role for ambulatory blood pressure monitoring, and then see whether you actually have low at certain times of the day, and of course, certainly whether the low times corroborates to the time the patient is experiencing the dizzy spells. Apart from ABPM, what other investigations have we not discussed that is relevant in patients with?
Maybe for elderly male patients that are suspecting carotid sinus hypersensitivity, especially the history of shaving. So you can actually, if you are able to do it, and if you are sure that the patient does not have a carotid artery disease, there's no past history of MI, there's no past history of stroke, you can actually do a carotid sinus massage just to elicit the cardioinhibitory form, in which you have a systole greater than 3 seconds, or the vasodepressor effect, where you have the blood pressure dropping 50 millimeters of mercury from the baseline. Okay. But like we said, I will not advise anyone to do it without at least doing a carotid Doppler or auscultate to make sure there is no breathe. So I will not readily advise us to do this routinely in our patients.
Okay.
Then other things that we might do is, if we are suspecting other cause of transient loss of consciousness, especially from the neurological aspect of view, EEG is very important.
Okay, so we'll get to that neurological part now. So I just want to describe how is carotid sinus massage done. From this slide, obviously what is going to be done is to massage the carotid.
Yes.
But you mentioned already that it should be done in an appropriate setting.
Yes.
When facilities for resuscitation is available,
yes.
when it becomes necessary. Then should have done the carotid Doppler. You should have listened for a carotid brew before and done a Doppler preferably to exclude significant atheroma or dissection or anything that can create any problems for us. And from the fact that we are going to be monitoring the BP and the ECG pattern, I will know that the person has to be on continuous ECG monitoring. And of course, blood pressure too has to be monitored. And of course, we need to know what we are looking out for. Basically, 3 seconds of asystole, like you said, or a drop in the blood pressure. Okay, so now we just talk about the big one a little bit before we round up the presentation. Like we talked about earlier, we're not going to be talking so much about management or treatment. It's just basically the evaluation. So how do we distinguish between the two bad guys? Is he a seizure, or is this person having a syncopal spell?
And maybe we should ask our people in the pool.
Okay.
Let's just seek their opinion about that.
Okay, so we'll do that. So I'll describe this case now. Please help join us in this poll, please, guys. So we have this 29-year-old woman that was brought in due to recurrent episode of fainting spells. She came with a brother who has witnessed a few of the episodes. Which of the following is more in keeping with a seizure rather than syncope? Which one says seizure? This is a multiple choice question. So let's
start
sharing this stuff now.
Let's try our best to answer. This will be a very good case to see to test you, and then we'll go over the answer together. Good. I can see people are voting. We have over 140 people online. Don't worry. We will not show the wrong person. A 29-year-old was brought in due to recurrent episodes of fainting. She came with her brother who witnessed a few episodes. Which of the following is more keeping with a seizure rather than a syncope? Loss of consciousness, 3 to 4 minutes. Able to stand up by herself immediately after. Symptoms happened when she was just sitting and reading quietly. Symptoms preceded by narrowing and blacking out of the visual field, nausea, sweating. Witness noticed slight jerks of hands and legs after she landed on the ground. So let's answer. We have 60 seconds more. We need more people to vote. Good. Only 17% have voted. Go ahead. If you are not sure, this is the time to show yourself, and then we will explain the answer afterwards. All right. I think I'll stop the polling now. We have about 47 participants. Great. I think the polling has ended.
So that's the distribution of the answers. I won't say now which is the correct answers. I think I'll wait for us to discuss the neurological aspects before we review it, and of course we'll ask us again what our thoughts are if there is time. So Dr. Adekon, what are the key things to consider when we're trying to when we're trying to determine whether someone is actually indeed having a syncopal episode or whether this was a seizure?
So that seizure is one of the closest differential diagnosis, and we have to be sure, especially with the various type of seizure that epilepsy that we have. So the first thing is there a trigger for this attack? Maybe bright lights, noise.
Mm-hmm.
Those are more in patients with
seizures,
vasovagal syncope than, but if it is to lights, it is more of seizure.
Okay.
But noise, sight, smell,
alt environment,
it is more in keeping of syncope. But
absolutely.
especially
and
lights, then the situations. Then what is the prodrome like? Aura, deja vu, some abnormal smell and whatever is more in keeping with seizure disorder. Then the duration, like we said, syncopal attack or syncope is very, very brief. Rarely lasts beyond a minute, very, very rarely 2 minutes. So someone losing consciousness for 3, 4, 5 minutes is likely due to a seizure episode. Both of them can have motor movement.
Okay.
But the motor movement in syncope is very, very brief.
Okay, so both of them can have motor
Both
movement.
of them can have
because of the cerebral hypoxia, hypoperfusion and hypoxia that happens during a syncopal episodes. So they can have those little maltonic jacks, but they should be slight, they're not so gross, and they're definitely not coordinated like what you typically will have in a seizure episode.
Yes.
Okay. So those are things that can help us distinguish to a variable extent. Injury
to the tongue,
almost always.
Sphincteric incontinence, more of seizure. Post-event sequelae, I think prolonged postictal phase, postictal confusion, postictal weakness is more in keeping with seizure, and that is the strongest.
Is one of the strongest.
Distribution factors.
So if you have someone that passed out and then the person just woke up and then realized what has happened and just wanted to get up, that what's happening, okay? But that suggests syncopal episode.
Yes.
But if you have someone that passed out and the person is waking up, almost like someone is waking up from his sleep, they're just waking up small, starting to open eye, looking around, what was going on. It took a while to get himself. In fact, slept a little bit on the floor before getting up. That is almost invariably a seizure. Okay. And the key point of distinguishing this is because in someone that has a seizure compared to syncope, the treatment is totally different. In fact, it's at opposite ends of the spectrum. And the clinical distinguishing point is very important because an EEG alone will not, because quite a number of normal people can also have an abnormal EEG. So the EEG should be interpreted in the clinical context
of this.
And of course, from the history, we should actually have an idea what we're thinking, whether we're thinking this person likely has a seizure or this person likely suffered from a syncopal attack. Now, talking about things like incontinence, we've mentioned that it can happen in both, but it's more common with seizure disorders. Now, the eyes is often open in both conditions, actually. But if you have tonic versive movement of the eye, so you have the eye just turned towards one angle, both eyes turned towards one angle, not in a neutral position, you're thinking more towards seizure. Okay, but in someone with syncopal episode that the eye was open, the eyes would just likely be in the neutral position. So that's important. And of course, people can be tired after a syncopal episode, but it's usually much more prominent in someone that had a seizure.
And the way the patient falls also is important, especially in patients with pseudo-seizure, pseudo-syncope.
Syncopal episodes.
Someone falling and trying to avoid injury. As in falling carefully, heavily guided falling, this is, especially if you have a video evidence, but like the person you talked about that actually broke the center table. There's no way you fake thing and you want to injure yourself in the process. And going by what our people chose from the poll, the timing is very important because that timing is long, about 3 to 4 minutes.
Absolutely.
So which is in favor. Then the issue of the myoclonic jack, like we said, it is common to both. And you might actually be confused by the eyewitness because they may not be able to describe. So using myoclonic jack alone to say it is seizure is a bit
difficult.
It's a bit difficult.
Okay. Thank you for highlighting that. I think the neurological evaluation, we've talked about the key thing in terms of imaging will be an EEG.
Yes.
A lot of people will need CT scan and MRIs,
yes,
particularly if you have shown clinically that it's likely to be a seizure. But doing brain scan for everybody that has syncopal episodes is not a pragmatic approach at all.
That's why they put it as a class 3. So there's no gain. Even routine EEG, except if you are most likely sure that it's due to seizure, not to talk of doing CT, doing MRI.
Okay. So of course, all those other things that can cause autonomic failures,
yes,
we should assess for using clinical and other parameters. And of course, what do you call it? Things to do for people that have TIA, apart from the brain scan, carotid Doppler scan, and will also be important. So
let's go back
to that case review. We are already showing the answer now. I wish you could actually. So, but in someone that has ECG abnormalities like that, usually there is a definite need for further cardiovascular evaluation. Okay,
yes.
There are many further cardiovascular evaluations we can do. We did mention a 48-hour Holter, which is available here. I know in other climes they can do a 7-day ECG monitoring,
yes,
which is going to be rather stressful. And then there's some implantable recorders that can also be used.
Months.
Apart from looking for further reading abnormalities like that, a lot of patients can also benefit from an echo, particularly older patients that had loss of consciousness. Please look for structural disease. You might want to trust your auscultation and believe that you can pick the ejection systolic murmur of AS or OCUM, but you may not pick it. So let the person get an echocardiography done, and in certain people in which you suspect ischemic heart disease as the cause of the arrhythmia or the potential arrhythmia the patient had. Say it again. Yes, coronary angiography will be in order for those kind of people. If it's acute, you can do a troponin and another time to try to find out what's going on. So all those things are things that can be further evaluate a cardiac cause of a syncope better. Don't forget that by the time you finish evaluating someone with syncopal episode, after your clinical evaluation, you should know that whether you are dealing with a reflex syncope attack. Once you cannot definitely say that it's reflex or autostatic, you need a fairly full cardiovascular evaluation for the patient
to make sure that there's no underlying cardiac problem
in the patient. I think there's a poll that we've not taken, so I want us to take a last poll now. Please let's participate. Then we'll go into question and answers before we round up.
Can we answer the last poll for them?
Can we do what?
Can we give them the right answer for the last poll?
Oh, it's to do an ambulatory.
Not to do.
Sir?
No. This last poll that you just did. Can we tell them the answer?
Okay. Oh, thank you very much. So the loss of consciousness
typically lasting 3 to 4 minutes is the best choice there.
No, it's multiple choice actually.
Okay.
It's multiple choice. So loss of consciousness lasting 3 to 4 minutes will be
suggest
a seizure. So that's one. Also, if the patient had a episode while sitting and reading quietly, well, suggest a seizure, even though of course it can also be
cardiogenic
syncope or seizure. Okay, so cardiogenic syncope or seizure, but will not go for vasovagal and will not go for autostasis.
Yes.
But of course, the strongest one here out of the 3 right answers here is the
jacks.
The jackiness. This jackiness will suggest syncope rather than
Because like you said, it can happen in both conditions. But if you are sure it is tonic-clonic movement the patient has, it is seizure.
Okay, but with a slight jack here, it's not out of place. It's not out of place for a syncopal episode.
Yes.
So I think the duration is, I would say A1 and then C maybe.
Positioning.
Okay, but A is the strongest answer. If someone passes out for 3 to 4 minutes, please, we should not call it syncope at all. We shouldn't even entertain syncopal spell in person. It's a seizure or other transient loss of consciousness, maybe, but not a syncopal episode. Because once the person falls to the ground and cerebral hypoperfusion is restored, usually within less than a minute.
The person
should be back. Person should be back up. Okay, but this is how people voted. I think I've shared that earlier. So we're going to do a last poll, and that's on evaluating suspected autostatic hypotension. So please, let's quickly look at this question now and vote. 52-year-old man that slumped at home. Was not sure how long it was out for. At presentation, it was just perfectly fine, but the doctor wanted to check for autostatic hypotension. So there are 4 answers. Let's choose, please. I thought we will get this much more than this because we covered some of these things actually. Polling was not so much. Wasn't so much.
I was almost saying we should not take this polling.
It's fine, actually. We're choosing the false answer. Don't forget, you're choosing the false. Which of the following is false?
If you have not answered, make an attempt. About 60% have voted.
Okay, so we can abort, right? Okay, so this is how we voted. Most people actually got it wrong. So this is just checking for autostatic hypotension. We said it during the course of the presentation that the person should lie down for a while before standing up.
Yes.
And the lying down for a while should be at least 5 minutes.
5 minutes.
Should be at least 5 minutes. So the person should lie down for about 5 minutes. You check the BP. Then the person stands up, and then you check it at 1 minute, and 3 minutes. So you should do at least twice. Only standing, okay? And of course, the drop in diastolic blood pressure,
greater than 10.
Anything greater than 10 is significant.
So this is 12. So
it's significant. So the answer A is number A. Okay, so the person should lie down for 1 minute is too short to acclimatize to elicit the changes we need to elicit. So, and I will encourage us that in every patient that comes with a collapse and has recovered, we should look for autostatic hypotension, especially in patients that have risk factors for autostasis. People on medications, on amlodipine, on vasodilators like nitrates, Viagra. Some men will use Viagra, they will not tell you, they will just tell you that they had the fainting spell. So we should look for all those things in such people. And of course, in people with autonomic issues, diabetes, Parkinson's, etc., etc. So I think we'll conclude now, then we'll take the questions.
Yes.
So Dr. Larikon, what are the take-home points?
So our take-home point is number 1, syncope is a symptom, not a disease. And we should try as much as possible to look for the underlying cause. Taking a good history, doing a detailed examination will help in about 50 to 60% of time to achieve your answer, to get what the diagnosis is. And this will help us to avoid doing unnecessary tests, CT and all the rest. Then the commonest cause of syncope is the neurally mediated one or the reflex syncope. But we should not forget, a patient can have a reflex syncope and also have a cardiac syncope. Then we should not forget also our psychiatric evaluation in patients with pseudo seizures, pseudo syncope, a panic attack, patients with breath holding spells. So it's important. Then we should not forget seizure, very, very common in patients presenting with what looks like a transient loss of consciousness. And like I put here finally, just having some knowledge of ECG will save us a lot.
The YouTube video on ECG is still there.
It's still there, so it is available for people to look at. So these are the take-home points we want us to take away from this presentation, and to know, like we said, that syncope may largely be from a benign cause, but it could have disastrous resultant effects in terms of syncope happening at work, during some important activity.
And irrespective of the underlying cause, we should not forget to give people driving advice. In people with syncopal episodes that are likely to recur, especially if it occurs in dangerous situations, then we should give them advice related to that situation such that they don't harm themselves or cause harm to others. So we'll just take a few questions here, Dr. Alekon. Christopher here is asking, how can we differentiate loss of consciousness of cardiac origin from that of neurological CNS origin?
I'm sure he's talking about cardiac syncope and reflex syncope. Like we said, presence of underlying structural heart disease, ECG abnormality, echo abnormality, then absence of some of those situational stuff we discussed about, the warning sign, the positioning, the situation preceding the event, and importantly, the history of syncope occurring during exercise is very, very important for cardiac syncope. And another thing is, most cases of cardiac syncope just occur abruptly. There is no warning sign.
So the prodrome of
is very,
feeling warm, can be absent.
Having that nausea, having that discomfort is very important in that class of patients.
And of course, we should always also remember to examine the pulse, check for postural changes in blood pressure, listen to the heart sounds. There you can actually pick up little things that tells you that there's something wrong in the cardiovascular system here, so that we can help the patient. So someone is asking about vasovagal syncope. I'm not sure I can understand the question very well. Okay, so the person has seen it. Okay, so again, vasovagal syncope is one of the reflex syncopes, and it's perhaps one of the commonest form of syncope that we see. So you get someone get the bad news, and the person just passes out. The person sees blood, and the person just passes out. And within a few seconds, the person is back up. So that's it. What's the difference between cardiac syncope and autostatic hypertension?
We talked about the autostatic hypertension due to that pulling and drop in that blood pressure. Absolutely. We've talked about how to differentiate it. Once you are able to establish
that there's
autostasis, likely the patient has autostatic.
And a patient with autostatic hypertension, nothing needs to be wrong with the heart. It's just the heart to have a vasodilatation for whatever reason. Autonomic failure, some drugs they're using,
some other medical condition.
So that's just the difference between autostatic syncope and the cardiac syncope. So we have another question now, that why does some patient pass out when taking intravenous medication such as ceftriaxone? Why do they pass out?
We talked about maybe anaphylaxis, vasodilatation.
Absolutely, and even there can be a vagal response to pain as well.
So it's still under
reflex syncope. So pain in some people can trigger that transient loss of consciousness. Some site of blood can trigger that vagal response. situations can do that. So, so if someone gets a painful medication, the person can pass out, and of course, but anaphylaxis will likely be the most dangerous reason why someone can be getting a medication and the person just gets widespread vasodilatation and then the person passes out. Okay,
we shouldn't forget passing out after urinating. We shouldn't forget passing out after urinating.
Yes.
Called mitigation syncope. So it's something that we should also keep in mind. And then, you know, passing out when they see blood. So sometimes that can be, but remember that you must exclude the other things. It's not uncommon for patients to have underlying problem and still have a near-immediate syncope on top. So the syncope may be a red herring, all right, but you must still use the opportunity of getting a full clinical evaluation for the individual.
Thank you.
Thank you. So someone is asking what can be done for a middle-aged man who has recurring syncopal attacks once or twice a year for several years? Cardiac investigation has been essentially normal, aside from bradycardia, 45 to 50 beats per minute. What do you say about that, Dr. Alekon?
Okay. The first thing I will say is the cardiac investigation for these patients is not normal. Mm-hmm. So this patient should be well evaluated because a 45-year-old man with heart rate of 45 to 50 beats per minute. So just the pulse examination of this person is not normal. So the cardiac evaluation of this person is not full. Okay, so this person
what evaluations would you think you should do for this person?
For this patient needs a detailed cardiovascular examination and investigation. This is the kind of patients that will not only do a rest ECG, we do an Holter ECG.
Because this heart rate you are getting 45 beats per minute in your clinic,
yes.
It can be 38 easily in his house or in his place, and then there may be many times that he's not going to get the appropriate sympathetic response of the increase in heart rate to exercise and physical activity. So that is very.
We must also remind ourselves that almost every time that there's syncope and a bradycardia that you pick up, that patient almost invariably will need a pacemaker. So we must always remind ourselves about that. That a patient with syncope and bradycardia that we pick up in the clinic will almost invariably need a pacemaker, except on very few occasions. So you should not take that lightly.
I think we easily forget that the normal heart rates, what we teach as normal, is between 60 and 100. Yes, 50-somethings are common, but by the time you're getting into the 40s with symptoms, even if you are not able to tie the symptom with symptoms to the heart rates, because I will keep on remembering Mr. Jack. That's the man that came, was septic. His heart rate was just in the maybe early 60s. Okay, but by the time sepsis was coming down, it was going to the 40s, and the man was still very weak. But by the time he got a pacemaker, and his heart rate was now able to cope with the demands of normal daily living. So that person needs further evaluation, and I will take this as symptomatic bradycardia until otherwise proven.
Exactly.
So someone states here that there are people that go around with BP of less than 90/60. Are they at risk for syncope? How do we manage patients whose BPs are typically low? That one is a. I think I'll try to answer that. I'll allow Dr. Aleka to contribute after. So there are a lot of patients that go around with low normal BP, and that is just their normal BP. Yes. But usually most of those ones are greater than 90 systolic. Yes. They are greater than 90. Almost everybody in which even regular systolic BP is less than 90. There's something going on, even if you can't pinpoint what it is. Okay, so that's one. Are they at risk for syncope? If the systolic is less than 90, yes, the person is at risk for syncope. So how do we manage patients whose BP are typically low? I would say that in patients in which their BP is low normal, and by definition, that's usually still greater than 90, yes, we don't need to do anything for them. But in patients in which their BP is lower than normal, and then they are symptomatic, either with dizziness and all of that, we need to find out what is wrong and treat it. That's the underlying abnormality. I'm not sure what I will give you as the likely possibilities. There may be cardiac issues, there may be dehydration. I think those are just the few things that can just generally come to my mind. I'll also tell you
it's basically looking for the underlying cause.
I will know that I've seen a few people with Addison's before, that their BP, they are fatigued, their BP is always around 90 somethings, and then by the time you treat that, that gets better. So now, I would say that, yes, sir. Please comment.
I will just add, one of the key things to do when you have a very low blood pressure is EUCR. That's one of the very key things. And then the next thing you can do is to do the ambulatory blood pressure. Is that blood pressure 90, 60 throughout the day? And does it get much lower? And do the symptoms that the patient is complaining of correlate with any of those low blood pressures? If there is no symptom correlating and there's a normal evaluation, then you can say, okay. But otherwise, if there are symptoms with an abnormal evaluation or the blood pressure goes significantly below that with symptoms, then there must be intervention. So sometimes it's not good to just leave people and say that they are asymptomatic or something. So we have to go a little bit further in a number of cases.
Thank you very much. So here's this question here now. Thank you for this presentation. My question is this: when ECG is not available, is there any other alternative for investigation? That's for syncope. What medication can be given? And then the medication given, is it the same for cardiac syncope or visual syncope or autostatic?
For this question, when there is need to do an ECG, you just have to do the ECG. There's no once you know that there's a reason for you to have an ECG done, there's no other way to do it than to look for an avenue or a site for that to be done. I know it might be difficult.
I think that's the final answer for that, actually. If you need an ECG, you need an ECG. Now, in terms of medication, I don't know whether, let me answer it. There's no medication for syncope, okay? But of course, if someone is still, there's no medication for syncope, let me just rephrase that. Syncope is a self-limiting condition, and it's more of an evaluation issue. Okay, but of course, if you pinpoint an underlying cause, you will be able to give advice, that's one. And of course, if there's cardiac issue, if there are cardiogenic issues, those may need to be resolved with medication, with devices, coronary angiography, pacemaker, etc., those kind of interventions. Now, for autostasis, usually, of course, you may need to adjust medication in the presence of medications. The only one that has some sort of medication is for people that have primary autonomic failure, in which sometimes we use, what's the this agent?
Is the Fudro.
We use some fluorocortisone one, and then some vasoconstricting agents. Their name midodrine. Thank you very much. Some agents that can increase the vascular tone to try to bring up the blood pressure. But the only downside of that is that they also cause supine hypertension. And many times the patient can actually be getting a lot of harm from hypertension. We had like 2 or 3 patients like that. I think I gave them glucocorticoids, if I remember very well. So sometimes we give them supine hypertension. And sometimes you need to do a trade-off between, because those kind of people now, if you do their blood pressure, if you're giving someone medication to increase the blood pressure because of primary autonomic failure or Parkinson-related autonomic failure, the blood pressure, by the time you're getting a blood pressure of 120/80 standing, by the time the person lies down, you may be running into 150/100, okay? And that one is not without its consequences. But generally speaking, there are no medications for syncope.
Even from the guideline, the European Society of Cardiology, American Heart Association, Rhythm Association, the only class 1 thing in the management is education.
Absolutely.
Teaching patients counter prayer maneuvers that can be done, hand grip, leg crossing, squatting. So all the drugs are in class 2A. So it is after you have done that and you cannot achieve results. So there is no drug per se. Every other drug is just helping to bring back that symptomatic, sympathetic tone back to the patient.
So someone says here, how easily can temperature cause a syncope? Now, fever itself does not usually cause syncope. It does not usually. It can slightly increase the risk, but it does not usually. But a hot environment can trigger the vasovagal response to cause a reflex syncope. So one of the classic situations in which someone can have a vasovagal syncope is someone that is in a hot, humid environment in a crowded area. So I remember many of those days in amphitheater, you have someone just passing out sometimes, and then the person just recovers within a very short time. So the place is crowded, hot, and humid. The chances of someone that is prone to vasovagal syncope having it is a bit higher. How do we interpret orthostatic hypotension, first minute or third minute? Actually, both of them are important, and they both reflect both the early onset or the delayed orthostatic hypotension. So don't forget that the interpretation of this orthostatic hypotension and orthostatic syncope is in context of the symptom. So if I have orthostatic orthostasis, that's significant drop in blood pressure in someone that does not have any symptoms, first of all, I should not be checking it in the first instance. But it's as an importance in someone that has symptoms of either dizziness or syncopal episodes. So if you find it present in someone that has syncopal episodes or dizziness, either first or third minute or both of them counts as a positive test. And of course, it should guide us on the interventions we do. At the least, for orthostatic hypotension, of course, I believe that we all know that at the least is to tell the patient to get up gradually, even if there are no medications to change. For some people with primary autonomic failure, we ask them to wear test stockings to reduce the capacity of the limb veins, such that pulling is less. Okay, do cardiac care hospital offer ECG classes or courses? Yes, we do ECG teachings intermittently. And I know we are going to be having ones very soon. These days is on Zoom, but we have a rich episode that is still on YouTube, one or two episodes actually. On ECG. So I think I will encourage us to avail us to look at those. And of course, we encourage people to post questions on ECGs under that video. And I think we'll respond to it from time to time. So there's a question here that what is likely wrong with a middle-aged man that occasionally feels dizzy when he stands up but no syncope attack for Dr. Oladeko?
We've talked a lot about this.
Absolutely.
So he might be having a pre-syncope.
Okay.
Because the only difference between a pre-syncope and syncope is that fall. It's not that loss of postural tone is not there, but everything is the same.
So in this
it needs to be evaluated.
So in this kind of person, I want to find out when the person is on medications or not. If it's not on medications, I will check for postural drop in blood pressure. If there's a significant postural drop, then I need to find out what is causing it. And most people that have orthostasis, that's postural drop in blood pressure, by checking this supine and irregular blood pressure, most people that have it are actually people on medications, that are a little bit hypovolemic, okay? But if those is not there, then we need to consider other things that can cause autonomic failure and check for other autonomic reflexes in the person and see what else could be causing that. We know that this kind of thing is actually much common in older people, and that's due to weakening of the autonomic response to standing up in older people. The last one is, what is the lower limit for blood pressure in investigating an elderly patient with syncopal attack with premorbid isolated systolic hypertension? What's the lower limit of normal? I'm not sure I understand the question very well.
So let me try to answer that. I think the person is trying to find out the patient has a low blood pressure, and before now the patient has been having isolated systolic hypertension. So just the systolic blood pressure was high before, and now how do we differentiate the lower limit? Now you must remember that from physiology, there's something called the Wind-Kessel effect that happens in the aorta. That means that the aorta begins to have almost a peristaltic motion when time blood is pushed through it. But when people get older, that peristaltic motion is lost, together with some problems with the valve, which may be just a little bit sclerosed. So as people get older with some sclerosis of the valves and thick and hardening of their aortic vessel, they lose the Wind-Kessel effect. So over time, they could have a wider and wider pulse pressure as they get older, especially with atherosclerosis. Now, if a patient already had a pre-existing wide pulse pressure, one of the things you must exclude is A, the presence of aortic stenosis, or B, the dilation of the heart or aortic regurgitational stenosis, aortic regurgitation, or if there's already a dilated heart. So it's very important to do an echo. Whenever anybody has an elevated blood pressure, it is key that you do a proper echocardiogram that evaluates the cardiac chambers and evaluates the aortic valve, especially in this kind of patient. Now, if this patient now comes in with a low blood pressure, one of the key tools you have and which you can which you can do in cardiac care, is to do a 24-hour ambulatory blood pressure monitor. Put a swig around the person's hand, an automated swig, which will be checking the blood pressure throughout the day. Over time, let the patient record what their activities are and any symptoms they had so that you can correlate it with the blood pressure. So by the time you do that, you can now see the difference. Now, it's quite important also to note that whenever there is a sudden change in blood pressure, typically downward, typically blood pressure has been high before and all of a sudden you start having low blood pressures. More often than not, there's some form of cardiac decompensation. So it's important to evaluate the heart, evaluate for a myocardial infarction, evaluate troponins, evaluate for a pulmonary embolism. And that could be something that could be quite key, especially now in this COVID era and a lot of COVID myocarditis and pulmonary embolism. It's important to do those things. Now, what will you treat that patient? It will depend on what you find. If you find episodic low blood pressure correlating with symptoms, then it means that you may have to use all the things that Dr. Officer has already talked about. If you find episodic problems with rhythm, then you may have to put in a pacemaker. If, however, you find that the patient is otherwise fine, but the blood pressure just dropped, you cannot find any other reason, one of the things you need to do are the cardiac biomarkers. You do the troponin, the D-dimer, and you evaluate the echo and the aortic valve. This will go a long way to be able to tell you what exactly is wrong. In some of those cases, they have developed a myocardial infarction, so the blood pressure was high and suddenly the blood pressure becomes low. It's important to check all those things and not assume anything. So I hope that answers the question on that.
Thank you very much.
Thank you very much, Dr. Alekan. John, let's answer this last question.
Somebody has the final question. What is the likely cause of blood pressure when the systolic and diastolic seem so close? Well, typically, systolic and diastolic can be close depending on whatever it is. But a lot of times when you have it very close, typically less, 130/100 is not even too close. When you get it less than 20, it typically occurs in settings of dilated cardiomyopathy or a dilated heart from hypertension. So if you go and do the echo, most times when you have 190, 110/90, 110/100, most times the heart is quite dilated and it's something that you should do. So what you do when you do that is to have a full evaluation, and that will help you. If you have 130/100, the blood pressure is not well controlled. You are not to reduce. So the patient is asking, which medication should you reduce? No, you need to readjust your blood pressure. If you go through our presentations on YouTube, we did one on hypertension and how to manage hypertension. We did on resistant hypertension. That will probably give you some light on that. Thank you very much.
Thank you very much, Dr. Scott. I just want to remind our partners and colleagues of the facilities that are available. Apart from coronary angiography and intervention that we do on a regular basis now, I think our volume is actually significantly increasing. But for this kind of patients, we can actually partner in doing investigations like a 48-hour 12-lead ECG, which can be helpful in going beyond the routine ECG and giving us the diagnosis that we require in our patients. Of course, we do also offer advanced echocardiography with speckle tracking. I'm not sure how many of us are familiar with what speckle tracking is, but it actually helps us map the myocardium better, and we're able to identify motion abnormalities and other pathologies of the myocardium for the patient. So that's another way that this can be helpful. And of course, patients with all sorts of arrhythmias, with heart failures, there are a lot of patients that have conditions in which they can actually benefit from many devices, apart from the regular pacemaker, cardiac synchronization therapy for people who have heart failure and EF is less than 35%, especially when the QRS complex is wider than 140 or 150 milliseconds. So those people usually benefit from CRT, and it can actually often improve their quality of life, their symptoms, and actually can even increase, generally overall will make them better. And of course, we have the ICDs, which is implantable cardiovascular defibrillator, which can help defibrillate patients and prevent sudden cardiac death in many patients that have structural heart disease, have advanced heart failure, hypertrophic cardiomyopathy, cardiac amyloidosis, and myocardial infarction. Unfortunately, we still have a lot of people who have myocardial infarction that is not recognized, and we'll see them in heart failure along the line. So there's a man who just discharged today now that has advanced heart failure. He had an MI, but his MI was actually not recognized on time, and because of that, he didn't get appropriate intervention on time. And now, just like maybe 4, 5, 6 months down the line, he's having heart failure. So I think we will encourage all of us to actually do better in evaluating and managing cardiovascular issues. And thankfully, not everybody has to fly outside the country to get things done these days now. So I think I would want to remind our audiences of that. Any other final comments, Dr. Alekon?
So I'll just also say that our audience, you will get emails after this of your CMEs. You also, if they can get the slides, you also may get the slides. And then when we have the next one, you also get an email. Please help us, or whenever you get the email or WhatsApp or text message, kindly help us share to other people. We believe that we can improve Nigeria by improving education, and we are doing this from Cardio Care. And then, of course, you can send your patients, we will co-partner, and then we'll send back feedback to you. So please, whenever you get our invite for webinars, don't hold it, share it on your Facebook, on your WhatsApp, in your medical groups. Make sure you invite at least 2-3 people so that we share the knowledge together and we get more interesting questions that we can walk around. Dr. Aleko, over to you.
Okay, thank you, Chief. Another thing I want to say is what we advocate for is a sort of partnership.
Absolutely.
When you have patient cases that you know need some of these investigations, you can actually send them, you get a feedback, and we work hand in hand for the betterment and for improved management of the patient. So all these things are available for us to help our patient and also to improve our practice. And like you said, we organize ECG seminars. We have our annual seminar, if not for COVID last year. That's why we couldn't do an on-site, in-person annual cardiovascular. So we have all this program packaged to help ourselves, and we want everyone connected to this program to share to as many people as possible so that we can learn from ourselves.
Then we will subsequently, we want to encourage people to not just ask questions by typing, but also verbal contributions, because I know that there's a different verve that you get when you hear someone express the questions verbally. And so we encourage people, so if, in subsequent sections, if you want to comment verbally, raise your hands, even though most of the time when we get people raising their hands, it's actually a typo, so to say. So, okay. But I think that will make it more livelier and more contributions from people. All right, I think it's time to call it a day. Thank you very much, guys, for your time. I'm hoping that we will all have some little things we can adjust in our practice from this. I think I've learned a lot while preparing for this presentation. And some of the things that Dr. Aleko and Dr. Iseko said actually has given me some insight, and I think I'll check a few things up additionally as well. So thank you everybody for joining. Hopefully within the next couple of weeks we'll have another good session together. I want to encourage people in the emails, you can also suggest topics. If you have some topics that you think are discussion worthy, that I think that we'll all learn from, I think it's something that I'll recommend as well. Thank you, everybody.
Thank you. Bye.
All right, bye, everybody. Thank you, Dr. Aleko.
Thank you, Sas.